Imagine you're just sitting at your kitchen table.
Right, just a totally normal morning.
Yeah, exactly. You're drinking your morning coffee, scrolling through the news, feeling completely normal, and then in a single second, I mean, literally the time it takes to snap your fingers,
Wow. Yeah.
the most agonizing, blinding headache of your life strikes. Just like lightning inside your skull.
It's terrifying to even think about.
It really is. It's a pain so absolute, so sudden, it just drops you to the floor. You try to call out, but the words come out, slurred. And maybe the right side of your body feels incredibly heavy.
And we need to be clear right away, this isn't a severe migraine.
No.
It isn't a bad flu. What you're experiencing is a catastrophic structural failure deep inside your brain.
Exactly. We're talking about a diagnostic landscape that is entirely hidden from the naked eye, where the stakes are literally life and death from second zero. So welcome to this deep dive.
Glad to be here.
Today we are pulling from a massive stack of medical literature, clinical notes, and some really incredible resources curated by iMedix.
Yeah, iMedix is fantastic.
They really are. For anyone who doesn't know, they're an independent medical information platform, and they're completely dedicated to patient education, tracking medication safety, and demystifying these incredibly complex, high-stakes treatment decisions that happen in the ER every day.
Which is so needed, honestly. The ER is chaotic enough as it is.
Oh, absolutely.
Yeah.
So our mission today is to decode the mechanics of a hemorrhagic stroke. We want to break down how it radically differs from the more common types of strokes and explore why knowing the difference between, say, a blocked pipe and a burst pipe can literally dictate whether you survive the day.
It's a vital distinction because the clinical reality of a hemorrhagic stroke is just drastically misunderstood by the general public.
Yeah, it really seems like we operate under this cultural monolith where all strokes are just viewed as a single disease.
Right, with a single treatment. But when you look at the pathophysiology, the actual biological mechanism of the injury, treating a hemorrhage, the way you treat an ischemic stroke is, well, it's one of the most fatal errors in modern medicine.
Right. Okay, let's pull that apart immediately then.
Right.
Because if 99% of the public hears the word stroke, they immediately picture a blood clot.
Yeah, a blockage.
Right. And that is an ischemic stroke, which makes up, roughly 85% of all cases?
That's right, about 85%.
Okay, so we are focusing on the other 15% today, the hemorrhage. What is fundamentally happening in the brain architecture during a bleed versus a blockage?
Okay, so with an ischemic stroke, you have a physical obstruction, like a thrombus or an embolus that gets wedged inside an artery.
Kind of like a cork in a wine bottle.
Exactly. And it completely starves the downstream brain tissue of oxygen and glucose. It's an infarction, meaning the tissue dies from lack of supply.
Right.
But a hemorrhagic stroke,
Yeah.
that is a mechanical rupture. The integrity of the vessel wall actually fails.
So it literally breaks open.
Yes. Blood violently escapes the circulatory system and physically injects into the brain parenchyma.
The parenchyma.
Yeah, the functional tissue of the brain.
Hmm.
Or it bleeds into the subarachnoid space surrounding the brain.
Got it. So it's basically a burst water main compared to a traffic jam.
That's a perfect analogy.
The supply lines haven't just stalled, they've exploded, and now they're flooding the surrounding infrastructure.
That is the exact mechanical reality. And to really grasp the unique devastation of that flood, we have to talk about the physics of the human skull.
Okay, I'm with you.
In neurology, we operate under something called the Monroe-Kelly doctrine.
Monroe-Kelly doctrine. Sounds intense.
It kind of is. Basically, the adult skull is a rigid, unforgiving vault of solid bone. It has a fixed internal volume.
Because it doesn't stretch.
Exactly, no stretch at all. Inside that vault, you have exactly three components. You've got brain tissue, which takes up about 80% of the space. You have cerebrospinal fluid. And you have blood, which is supposed to be securely contained inside the vascular network.
Okay, so three things in a box that cannot get any bigger.
Right, and the doctrine states that if the volume of any one of those three components increases, the volume of another must decrease. Otherwise, the pressure inside the entire vault will just skyrocket.
So there's nowhere for the pressure to go.
Nowhere. So when a vessel bursts, you suddenly introduce this massive, rapidly expanding volume of arterial blood into a space that has zero extra room.
Wow, so the expanding pool of blood is what, physically crushing the brain tissue against the inside of the skull?
Yes, it's brutal. The hematoma, the pool of blood, it literally dissects the white matter tracts.
It rips them apart.
It rips apart the neural circuitry through sheer physical force. It compresses adjacent structures, and it elevates the intracranial pressure to a point where it can actually collapse the healthy blood vessels nearby.
Wait, so the bleed can cause a blockage?
Yes. It can cause secondary ischemic strokes just from the compression alone.
That is horrifying.
It is. But here's the thing. The mechanical destruction is only phase 1.
There's a phase 2.
There's a secondary chemical phase of destruction that is arguably more insidious.
I mean, blood is the lifeblood of the body, right? It carries our oxygen.
Yeah.
How does it become destructive just by crossing the vessel wall?
Well, the brain has a highly specialized security perimeter. It's called the blood-brain barrier.
Okay, I've heard of that.
Yeah, it's formed by these extremely tight junctions between the endothelial cells of the blood vessels, and they're wrapped in the foot processes of cells called astrocytes.
So it's like a heavily guarded border wall.
Exactly. This barrier meticulously regulates what gets into the neural tissue. It keeps out pathogens, heavy metals, even fluctuating hormones.
Makes sense. The brain needs a stable environment.
Right. But when a vessel ruptures, that barrier is completely bypassed. Red blood cells flood directly into the neural environment.
And the brain tissue has, what, no defense mechanism for whole blood?
None at all. It's not supposed to be there.
Yeah.
Within hours, those trapped red blood cells begin to break down. They undergo a process called hemolysis.
Hemolysis, so they're rupturing.
Yeah. And they release hemoglobin into the extracellular space. Now, hemoglobin contains heme, and heme degrades to release free iron.
Okay, iron. That doesn't sound too bad.
Well, in the systemic circulation, free iron is tightly bound and managed. But in the brain parenchyma, free iron acts as a potent catalyst for something called the Fenton reaction.
The Fenton reaction, what does that do?
It generates a massive wave of highly reactive hydroxyl radicals. Basically, free radicals that literally shred the lipid bilayers of the surrounding neuron.
Oh my God, so it's chemically burning the brain tissue.
That's a great way to put it, yeah. It induces severe oxidative stress and this runaway inflammatory cascade. Microglia, which are the immune cells of the brain, swarm the area.
Trying to fix it.
Right, but they release cytokines that break down the blood-brain barrier even further, which causes massive fluid shifts and cerebral edema.
Swelling.
Extreme swelling. So the brain is simultaneously being mechanically crushed by the volume of the blood and chemically poisoned by the degradation products of that exact same blood.
That's a nightmare scenario.
It really is.
So if the underlying pathology of a clot, the starvation of tissue, is so profoundly different from the explosive chemical trauma of a hemorrhage, why do medical professionals and the public still use the exact same umbrella term, stroke, for both of them?
It's actually a relic of medical history. It's something we are still fighting today, honestly.
Really? Just historical baggage?
Basically, yeah. The word stroke originates from the ancient Greek concept of apoplexy.
Apoplexy, meaning what?
Meaning to be struck down by violence. You see, for thousands of years, physicians couldn't see inside the closed box of the skull.
Right, no x-rays back then.
Exactly. They could only observe the sudden, catastrophic loss of neurological function. A patient abruptly lost the ability to speak or, move half their body.
So the external signs were identical.
Completely identical. The clinical presentation looked the same, whether the internal mechanism was a clot starving the motor cortex or a bleed crushing it.
So they were diagnosing the result, not the cause, because the cause was invisible.
You hit the nail on the head. It wasn't until the widespread clinical adoption of the CT scan in the late 70s and 80s that we could reliably and rapidly look inside a living human brain.
And actually differentiate a blockage from a bleed.
Right. But by that time, the singular concept of a stroke was permanently embedded in our medical lexicon.
That makes so much sense. Okay, let's track back to the infrastructure failure itself. The burst pipe.
Okay.
Because blood vessels don't just spontaneously explode for no reason in healthy tissue, right?
Rarely, if ever.
Looking at the clinical notes from iMedix, there are 3 primary structural failures responsible for hemorrhagic strokes: uncontrolled hypertension, aneurysm rupture, and vascular malformations.
Those are the big 3, yes.
Let's start with hypertension, because I think people hear high blood pressure and they just tune it out.
Oh, absolutely. They think it's just a warning.
Yeah, it's just a nagging number at the doctor's office.
Yeah.
But mechanically, what is uncontrolled high blood pressure doing to the microscopic architecture of the brain?
Well, it's fundamentally remodeling the vascular architecture, and not for the better.
How so?
Think about it like this. The human heart beats roughly 100,000 times a day.
100,000, wow.
Yeah. And each beat sends a pressurized wave of blood through the arteries. Now, healthy arteries have a muscular layer, the tunica media, and an inner lining called the endothelium.
So they're flexible.
Very elastic. They expand to absorb the systolic pressure wave, and then they recoil.
They act like shock absorbers.
Exactly like shock absorbers. But when you have chronic uncontrolled hypertension, say 160 over 100, day in and day out, that pressure wave hits the arterial walls with relentless, violent mechanical shear stress.
So the shock absorbers are just constantly maxed out.
Yes, and over years, this shear stress physically damages the endothelial lining. The body tries to heal this microscopic damage by triggering an inflammatory response.
Which usually sounds like a good thing.
Usually. But here, macrophages infiltrate the vessel wall, smooth muscle cells proliferate abnormally, and plasma proteins leak into the muscular layer.
So the body's attempt to reinforce the pipe actually ruins it.
Bingo. It causes a condition called hyaline arteriolosclerosis. The flexible, elastic vessel wall is replaced by a rigid, necrotic, brittle
A
tube.
brittle tube in the brain. That sounds like a disaster waiting to happen.
It is. And in the brain, this is particularly devastating to the deep penetrating arteries, specifically the lenticulostriate arteries.
Lenticulostriate?
Yeah, they branch off the middle cerebral artery at these sharp, almost 90-degree angles, and they feed the deep core structures of the brain, like the basal ganglia.
And because of that sharp angle, they take the direct, unbuffered force of the high blood pressure.
They take the full brunt of the hemodynamic hammer.
The hemodynamic hammer. That's a terrifying phrase.
Under decades of pressure, these rigid arteriolosclerotic vessels develop microscopic outpouchings. We call them Charcot-Bouchard microaneurysms.
Okay, microaneurysms.
They are incredibly fragile. Eventually, just a single spike in blood pressure
Like lifting something heavy.
or a moment of extreme stress, yeah, it's enough to shatter the brittle wall, the vessel snaps, and you have a massive hypertensive intracerebral hemorrhage deep within the basal ganglia.
And the really terrifying part is that this entire process, this hyaline arteriolosclerosis, it's completely silent, right?
Completely silent.
You don't feel the vessels turning brittle. There are no nerve endings warning you that your arteries are degrading.
It is entirely asymptomatic until the second of catastrophic failure.
Wow.
Which is exactly why iMedix focuses so heavily on the pharmacology of prevention.
The blood pressure meds.
Exactly. Antihypertensive medications like ACE inhibitors, calcium channel blockers, beta blockers, they do not just change a number on a chart.
They're actually doing structural work.
They actively reduce the mechanical shear stress on the endothelium. They halt the progression of arteriolosclerosis.
So when you skip your blood pressure medication because you feel fine.
You are allowing that hemodynamic hammer to continue pulverizing the microvasculature of your brain.
That reframes the entire concept of medication adherence. I mean, it's not compliance, it's structural preservation.
That is exactly what it is.
Let's move to the second cause, the aneurysm rupture. How does the pathology of an aneurysm differ from the chronic wear and tear of hypertension?
So an aneurysm is a localized structural defect. It's a distinct weak point in the wall of an artery.
Okay.
The most common type in the brain is a saccular or berry aneurysm. These typically form at the major bifurcation point.
It's forks in the road.
Right, the forks in the road of the circle of Willis, which is the primary arterial ring at the base of the brain.
Why do they form at the forks?
Because the hemodynamic stress is highest where the blood flow splits. Due to, say, congenital defects or long-term wear, the muscular layer of the vessel can be completely absent at these junction points.
Oh, wow.
Yeah. You are left with only the thin inner and outer linings to hold back systemic arterial pressure.
It's like a weak spot on an old bicycle tire inner tube. It just starts ballooning outward under the pressure.
Exactly. It forms a thin-walled blister on the side of the artery, and as the aneurysm grows, the wall stretches and degrades.
It gets thinner.
Right. And there's this concept in physics, the law of Laplace. It dictates that as the radius of the aneurysm increases, the wall tension increases exponentially.
So the bigger it gets, the faster it weakens.
Exactly. Eventually, the wall tension exceeds the tensile strength of the tissue, and the blister pops.
And where does that blood go?
Because these aneurysms are typically located on the surface of the brain, the arterial blood blasts directly into the subarachnoid space.
Which is the fluid-filled area between the brain and the skull.
Yes, this is what we call a subarachnoid hemorrhage.
Which brings us to the third structural failure detailed in the iMedix files, Arteriovenous malformations, or AVMs.
AVMs, yes.
We're talking about congenital defects here,
Yeah.
right? Like a structural nightmare you're just born with.
Yeah, an ADM is a profound embryological failure of the vascular plumbing.
How does it happen?
Well, to understand why it's so dangerous, look at normal circulation. Blood leaves the heart through thick-walled, high-pressure arteries.
Right.
But before it reaches the thin-walled, low-pressure veins to return to the heart, it must pass through a capillary bed.
Okay, the capillaries.
Capillaries are these microscopic, highly branched networks that act as a massive pressure buffer. They step the arterial pressure down to almost zero.
To allow for the slow exchange of oxygen and nutrients?
Exactly.
So the capillaries are basically the safety valve between the fire hose and the garden hose.
That is a brilliant way to put it, yes.
Yeah.
In an AVM, that capillary safety valve is completely missing.
Wait, totally missing.
Missing. A high-pressure artery connects directly to a low-pressure vein.
Oh, no.
The area where they connect is a chaotic, tangled knot of abnormal dilated vessels. We call it a nidus.
So you are blasting high-pressure arterial blood directly into veins that have absolutely no muscular layer to handle it.
Right. The veins become massively engorged and tortuous. The blood flow through the nidus is incredibly turbulent, which creates extreme shear stress on the abnormal vessel walls.
They just get stretched to the limit.
Over time, these tangled vessels stretch, weaken, and they become highly prone to spontaneous rupture.
It sounds like a literal ticking time bomb.
It really is. And patients often have no idea they even possess an AVM until it hemorrhages.
That is so scary. And because these three major structural failures, the brittle microvessels from hypertension, the ballooning aneurysms, the tangled AVMs, they're all entirely hidden inside the closed box of the skull.
Out of sight.
Right. Which means we are entirely dependent on external alarm bells to recognize that an event has occurred.
Yes. And this is where the speed of recognition dictates the trajectory of a human life.
The clinical presentation of a hemorrhage is violent, and it is immediate. The sources outline a very specific symptom profile, right? Sudden severe headache, vomiting, weakness, confusion, and rapid loss of consciousness.
That's the classic presentation.
Let's link the internal biological trauma we just mapped out to these external alarm bells. Starting with the headache.
Okay.
Because the brain itself doesn't actually have pain receptors, right? Like, neurosurgeons can operate on the brain parenchyma while the patient is awake.
That's true. The parenchyma is insensate.
So what exactly is screaming in agony during a hemorrhage?
Well, the parenchyma can't feel pain, but the meninges, those are the three protective layers of tissue wrapping the brain and spinal cord, they are heavily innervated by nociceptors.
Pain receptors.
Specifically from the trigeminal nerve. Also, the major blood vessels at the base of the brain are surrounded by dense pain fibers.
Oh, I see.
So when an aneurysm ruptures and arterial blood violently injects into the subarachnoid space, it causes massive instantaneous stretching and chemical irritation of the meninges.
It's meningeal irritation on a catastrophic scale.
It produces what neurologists call a thunderclap headache.
A thunderclap headache.
It reaches maximum blinding intensity within seconds. Patients who survive universally describe it as the worst headache of my life, or they say they felt like they were literally struck in the back of the head with a baseball bat.
That paints a vivid picture. And the vomiting.
Yeah.
Because people usually assume vomiting is gastrointestinal, like a stomach bug or food poisoning. Why does a brain bleed cause sudden projectile vomiting?
It is a purely neurological reflex. It's driven entirely by that rapid spike in intracranial pressure we talked about.
Because of the rigid skull.
Right. As the hematoma expands and the pressure inside the skull skyrockets, that pressure transmits downward toward the base of the skull, and it physically compresses the brainstem.
Okay, the brainstem.
The brainstem houses the medulla oblongata, and within the medulla is the area postrema, which is the brain's vomiting center.
It's being mechanically squeezed.
Yes. The area postrema is actually one of the few regions of the brain that lacks a traditional blood-brain barrier.
Really? Why?
Normally, that allows it to detect toxins in the blood and trigger vomiting to expel them.
Oh, that makes sense.
But in a hemorrhagic stroke, it is the acute mechanical compression and the sudden distortion of the brainstem that forces the area postrema to fire wildly.
Causing sudden, forceful projectile vomiting without any prior nausea.
Exactly. No GI illness at all, just pure mechanical reflex.
That leaves the focal neurological deficits, the sudden weakness on one side of the body, the aphasia, the confusion.
Right. Those symptoms correspond to the specific anatomical territory where the blood is pooling and crushing the tissue.
Can you give me an example?
Sure. If a hypertensive hemorrhage occurs in the left putamen and internal capsule,
What happens there?
that's where the major motor tracts run from the cortex down to the spinal cord. The expanding blood mass physically shears and short-circuits those tracts.
And because the motor pathways cross over in the brainstem.
A bleed on the left side of the brain produces sudden flaccid paralysis on the right side of the body.
Got it. And what about the confusion and the loss of consciousness?
That occurs when the global intracranial pressure gets so high that it begins to compromise blood flow to the reticular activating system in the brainstem.
And that system does what?
It's responsible for keeping you awake, so the confusion and passing out, that's the brain slowly shutting down its own systems to survive the hypoxia and the pressure.
It's literally powering down.
Yeah.
But wait, people get terrible migraines with auras, right? People get severe stomach bugs. How does an ER physician or even just a highly observant family member look at a vomiting patient with a headache and know for sure it's a subarachnoid hemorrhage and not just a terrible migraine?
It's a great question. The absolute neon flashing differentiator is the speed of onset.
The speed.
The key word is sudden. A migraine builds. It creeps in over minutes or even hours. You feel the prodrome, the photophobia, the gradual escalation of the throbbing pain.
It ramps up.
But a hemorrhagic stroke hits maximal intensity in a fraction of a second. The suddenness of the maximal pain paired with the immediate onset of focal neurological deficits.
Like trying to stand up and realizing your leg won't support your weight.
Right. That pairing is the hallmark of a ruptured vessel.
Which catapults us right into the emergency room response.
Yeah.
Because the clock starts the second that thunderclap hits.
Yes, every minute is millions of neurons dying.
But here is the terrifying bottleneck in acute neurology. When EMS rushes you through the doors of the ER, the doctors cannot begin treating the stroke immediately based on your symptoms alone.
They absolutely cannot.
Why not?
Because despite the distinct nature of the thunderclap headache, the clinical presentation of sudden hemiparesis, facial droop, and slurred speech can happen with both an ischemic blockage and a hemorrhagic bleed.
So they look identical from the outside.
A massive ischemic stroke in the middle cerebral artery territory looks clinically identical to a large hypertensive hemorrhage in the basal ganglia.
When guessing wrong is fatal.
Very fatal. The very first step in the protocol before a single drop of targeted medication is authorized is an unenhanced, non-contrast CT scan of the brain.
They have to look inside the closed box. But why non-contrast? Why not use the dye to see the vessels better?
Because acute extravascular blood that has just poured out of a ruptured vessel is hyperdense. It absorbs X-rays incredibly well.
Oh, interesting.
On a non-contrast CT scan, acute blood shows up as a brilliant, bright white mass against the dark gray background of the brain tissue.
So it's instantly visible.
Instantly. If you use IV contrast dye, the dye also shows up as bright white in the blood vessels.
Oh. And that could mask it.
Exactly. It can completely mask a small hemorrhage. The non-contrast CT is the gold standard to answer one single binary question.
Is there blood outside the pipes or not?
Precisely.
Let's use an analogy to map out exactly why that CT scan is the absolute bottleneck of survival.
I like analogies.
It's the difference between a grease fire and a wood fire in your kitchen.
Okay.
If you have a wood fire, which represents an ischemic stroke, you throw water on it. The water cools the wood, puts out the fire, and saves the house.
Right.
And the water in this scenario is a class of drugs called thrombolytics, clot busters.
Specifically, recombinant tissue plasminogen activator, or PPA.
TPA.
It is a biological miracle for ischemic strokes.
How does TPA actually work?
When a clot forms in an artery, it's held together by this tough, fibrous protein mesh called fibrin.
Okay, fibrin.
TPA is an enzyme that travels through the bloodstream and binds to the fibrin in the clot.
And then what?
It activates a protein called plasminogen, converting it into plasmin. And plasmin acts like a pair of molecular scissors,
Slicing up the mesh.
rapidly slicing up the fibrin mesh. The clot dissolves, blood flow is restored, and the starving brain tissue is rescued.
You throw water on the wood fire.
Exactly.
But what happens if the physician assumes the sudden paralysis is an ischemic clot, skips the CT scan, and administers TPA? But the patient is actually having a hemorrhagic stroke, a grease fire.
If you throw a bucket of water on a grease fire, the water instantly vaporizes, violently scatters the burning oil, and burns the entire house to the ground in seconds. If you administer a powerful systemic clot-busting enzyme like TPA to a patient whose cerebral vessels have just ruptured, You eliminate the body's only defense mechanism.
Because the body is desperately trying to build a clot to plug the hole in the burst pipe.
Exactly. The coagulation cascade is working in overdrive to form a hemostatic plug at the rupture site.
And the TPA destroys it.
TPA will immediately seek out and dissolve that life-saving plug. It strips away all coagulation ability.
Maybe you bleed out faster.
You amplify the hemorrhage exponentially. The hematoma will rapidly expand. The intracranial pressure will spike. Brain herniation will occur. And it is almost universally fatal.
Wow.
This catastrophic pharmacological error is why the CT scanner is the most important piece of real estate in the hospital for a stroke patient.
That is intense. And this precise mechanism is the cornerstone of iMedix's warnings regarding patient safety and self-medication at home.
Oh, the self-medication problem is huge.
If someone experiences sudden weakness or a terrible headache, there is this very common, very dangerous reflex to reach for the medicine cabinet. They think, oh, maybe it's a heart issue, maybe it's a clot, I should chew an aspirin.
It is a terrifyingly common scenario. Aspirin is an antiplatelet agent. It irreversibly acetylates the cyclooxygenase enzyme.
Which knocks out thromboxane A2 production.
Right.
In English, it permanently breaks the platelets so they can't stick together.
Yes. For the entire 7 to 10 day lifespan of that platelet, it cannot participate in forming a clot.
So if you are having a myocardial infarction, a heart attack aspirin is brilliant.
Life-saving. But if you are having a hemorrhagic stroke, you have just ingested a powerful antiplatelet drug while actively bleeding into your brain.
You have chemically sabotaged your body's ability to patch the burst pipe before the ambulance even arrives.
Precisely. You cannot self-diagnose a stroke at home. The only clinically viable action is dialing 911 immediately so the hospital can clear the CT scanner before you even roll through the doors.
This life or death difference between the grease fire and the wood fire really highlights a massive gap in public understanding.
A huge gap.
We rely so heavily on public health campaigns to educate the masses, but those campaigns often oversimplify the reality to the point of creating dangerous blind spots.
Yeah.
Like, let's talk about the FAST acronym.
FAST. Face drooping, arm weakness, speech difficulty, time to call 911.
It's an incredibly successful campaign.
Huh?
I mean, it's taught millions of people to recognize a stroke. But looking at the iMedix analysis, the FAST acronym is heavily biased toward one very specific type of event.
It is heavily biased toward ischemia in the anterior circulation of the brain.
Specifically, the middle cerebral artery.
Right, which controls motor function for the face and arms and houses the language centers. FAST is brilliant for identifying the classic middle cerebral artery clot.
But what is completely missing from the FAST acronym?
The thunderclap headache, the projectile vomiting, the rapid loss of consciousness.
They aren't in there at all.
Exactly. And because the cultural monolith of the word stroke has trained the public to look only for a drooping face and a weak arm, a patient who experiences a ruptured aneurysm might completely misinterpret their symptoms.
That's chilling. So if a subarachnoid hemorrhage hits, and the patient has an agonizing, blinding headache and sudden vomiting, but they can still lift both arms and speak clearly.
Their family might not call 911.
They think it's just the worst migraine of their life, or food poisoning.
Right. They take an aspirin, go lie down in a dark, quiet room, and they bleed to death in their sleep because the intracranial pressure slowly crushes their brainstem.
That is the tragic reality of medical oversimplification.
It really is. The cultural narrative of a stroke, reinforced by movies and television where characters just clutch their arm and slur a word, it creates fatal hesitation when a real-world hemorrhage doesn't match the movie script.
And in acute neurovascular emergencies, hesitation is brain death.
100%.
Which is exactly why independent medical literacy, the kind pushed by platforms like iMedix, is so profoundly empowering. If you understand the deep physiological mechanics we've mapped out today, the difference between the blocked pipe starving the tissue and the burst pipe poisoning the vault,
You are fundamentally transformed as a patient and as an advocate for your family.
it replaces panic with clinical orientation. Like, if you are standing in the ER with a parent who just suffered a sudden neurological collapse, you aren't going to be screaming at the triage nurse asking why they haven't given your parent the clot-busting drugs yet.
Right, because you understand the grease fire. You understand why the physician is ignoring the drug cart and rushing the stretcher directly to the non-contrast CT scanner.
That level of physiological literacy allows you to be a calm, integrated part of the diagnostic process, rather than a frantic barrier to care.
It strips away the horror movie element of an emergency and replaces it with a mechanical understanding of human biology.
Well said. We've covered an immense amount of ground today. We completely redefined the hemorrhage, not just as bleeding, but as the violation of the Monroe-Kelly doctrine,
The physical crushing of the brain within a fixed, unforgiving vault.
compounded by the chemical toxicity of hemoglobin breaking down into free iron and shredding the lipid bilayers of neurons.
We examine the invisible structural degradation that sets the stage for the catastrophe.
Right, the constant, relentless hemodynamic hammer of uncontrolled hypertension causing hyaline arteriolosclerosis, turning flexible microvessels into brittle necrotic tubes,
And the ballooning of saccular aneurysms at the high-stress forks of the Circle of Willis.
and the embryological nightmare of AVMs where high-pressure arterial blood bypasses the capillary buffers and slams directly into fragile veins.
We map the alarm bells, too. The trigeminal nerve endings in the meninges screaming in agony to produce the thunderclap headache.
And the sheer physical pressure compressing the medulla oblongata to trigger projectile vomiting. And most importantly, we established why the unenhanced CT scan is the absolute non-negotiable bottleneck of modern stroke care.
We must look inside the box to ensure we don't drop a metabolic bomb like TPA onto an active cerebral hemorrhage.
Exactly. I want to leave you with a final provocative thought to carry with you long after this deep dive ends.
Okay.
The next time you're sitting in a clinic and the nurse wraps that Velcro cuff around your arm to check your blood pressure, don't zone out.
Because so many people do.
Most of us just sit there, wait for the uncomfortable squeeze to deflate, and if the nurse doesn't look panicked, we completely ignore the numbers. We treat it like an arbitrary grade on a minor quiz.
But those numbers represent the exact amount of physical shear stress currently battering the delicate endothelial lining of your lenticulostriate arteries.
Exactly. I challenge you to reframe that entire interaction. That blood pressure cuff is not checking a static number.
No, it's not.
It is performing a real-time structural stress test on the most complex, irreplaceable vascular plumbing in the known universe.
It is a direct measurement of how fast your internal infrastructure is degrading.
Ask yourself, are you allowing the hemodynamic hammer to quietly pound away at your foundation, turning your vessels brittle and weak? Or are you actively managing the physics of your own biology?
It's a powerful way to look at it.
The diagnostic landscape of the brain may be hidden behind an impenetrable wall of bone, but the daily actions we can take to protect the machinery inside are entirely within our control.
Absolutely.
Look beneath the surface of the things you think you understand. Stay intensely curious. And thanks for joining us on this deep dive.